Hello and welcome to this week's hot topic, which is falls prevention. Now, the reason I'm doing this is because I work across a lot of care homes in the southeast and across London, and it's quite clear there is a disparity within falls prevention training and understanding. And I say this because I've currently seen one report when CQC goes in around falls prevention on the forensic approach that they take to this. And this is important because we are all responsible for falls. We're all responsible for understanding what needs to be done. And we are all responsible for ensuring the policies and procedures are read and understood, that we as staff know how to handle that, from cleaning staff to care staff to nurses to home managers and to owners. And ultimately, your training is fit for purpose. So what I want to do is I want to run through an NHS's policy, because the National Health Service policy for this is quite rigor. It covers all of the key aspects that we need to talk about. So let's have a look and let's go. So here we've got our falls policy. The first thing to make sure is that you are reading the most current up-to-date ones. So just make sure the ones that you read are current and up-to-date. If there are any changes or amendment to it, a change log is a great way to demonstrate that you have gone through internal quality assurance to make sure that they're up-to-date. But for you as the reader, so whether you're care staff right through to the homeowner, you understand that it's been updated. We then run through the evidence, so why we do this. So here you can see that they're on an increase and that we've got the National Institute for Care of Excellence guidelines. So you must make sure that your policy refers to the latest evidence of NICE guidelines, okay? And we'll talk about those in a second. So the approach that you need to take looks at improving falls management, reducing incidences, improve resident outcomes. So we've got three strategies or three approaches in which we hope this policy and procedure will cover. So just go back to yours, see if yours does that. So the first one then is improves falls management. So the strategy for falls management, you can see is below, and that's to be aware of falls through mandatory training and governance, assess the falls through risk management processes, address those factors, and then act upon them. So here, act, aware, assess, address. So that's quite a nice policy there, framework to work there. It looks at the scope, so it kind of suggests who's more at risk here. So here we can see this is aimed at 65-year-olds and above. It's aimed for people that have had a history of fallings, and then those that are more at high risk of fallings because of underlying mobility problems or health conditions. So it does go very clinical. So if you don't do clinical within your service, you need to be a bit more clinically aware now. So it's important that you address the NICE guidelines within this. So if you highlight those and you search those, just make sure that the NICE guidelines are current and up to date. So here, falls in older people assessing risk and prevention. So it runs through what you need to do. So please make sure you read that and that you're up to date on that one. And then in this one, it tells you the steps in which you should be taking, which is where your policy is written from. So these are your quality statements that you can see here. So statement one, you need to identify the people at risk. We've just done that. So over 65, those with medical conditions, and those with a history. We need to look at those risks. We need to look at the interventions. We need to look at the checks. We need to look at safe handling. We need to look at medication, etc. But all of this is then put into your policy. So that's what you're aiming for. You're aiming for all of this to go into your up-to-date policy and procedure. So once you're confident that your policy meets those NICE guidelines, We then move into the purpose. So the purpose of this policy is to raise awareness amongst staff. So just think about, as staff, how do you know you're on the latest version? And as a care manager, how do you know that you're on the latest guidance? You obviously want to reduce the risks of falls, and you want to ensure that there's a standardized approach. So in other words, test this out. So in your services, do fire drills as risk to falls as if you would fire drills. So have a member of staff lay on the floor, see what happens, see if the staff follow the policy correctly. And if you've got like a falls fire drill log, you can show that staff have been trained. Here you've got the definition. So we've got falls in the event where the individual falls to the ground, slips where they accidentally slipped or they lose their balance, trips where they stumble accidentally, hazards where they fall over something that's potential, or risks. Now, what's not on here are sudden drops. So if somebody has a medical condition and it's a sudden drop, we need to be clear that that's not a slip, trip, or fall, but it's a sudden drop. However, with sudden drops, you will probably follow exactly the same protocol if it was unwitnessed, because you don't know that it wasn't a slip, trip, or a fall. But if you have witnessed a sudden drop, so that's just the giving of the legs and somebody just falls, so it's not like they're wobbling, they just drop, the sudden drop, then you should probably have a sudden drop policy that explains that, and the head to toe and the medical stuff as well around that. So we look at the duties and we look at the procedures. So here, staff level of awareness. So staff level of awareness around prevention of falls. There's lots of stuff that you can do online. There is free online training for this. If you are a nurse, you should be completing blood pressure as well, lying and sitting and standing. You then need to look at root cause analysis. So you should look at root cause analysis, carry out investigations on all falls, and not all serious falls, but all falls. So lessons can be learned to prevent similar accidents. And again, you need to look at the responsibilities for fall governance, training and development. So we also need to involve residents and carers. So look at the residents, look at the named nurses, and look at those risk assessments and care plans. So that might be education for the resident that you want to give, so a bit of education there. It might be core balance and a bit of OT referral to get their strength up, to understand that their own risks are there. 6.2, you want to then assess the individual risks. So at this point, you need to show required documentation. And there, ideally, this should be completed at the earliest opportunity, but within a 42-hour time frame for when somebody comes into your home. So the sooner the better, because if somebody has a fall within that time, you're going to be in trouble. So falls assessment should be done pretty much immediately, really. The falls risk assessments and the management plans are live documents. Once they're there, keep them updated. You're then going to need medical assessments. So again, it's down to the GP to make sure that medication reviews are taking place, that the plans are there, especially if there's a risk to osteoarthritis or other histories of fractures. Bear that in mind. Nutritional assessments. So again, the BMI calculator of must scores, that would look at the, ensuring their balance, their blood sugars, their skin integrity, and all of those other parts. The environmental factors, so doing your floor walks, making sure it's safe, and then the overview of the resident, making sure that it should be easily identifiable for all staff members on shifts. We need to address the prevention of falls through assessing identified risks. So, for example, we know those risks are walking aids, if they're not being used correctly, footwear, so making sure that residents have the right footwear on. We're looking at hypertension, So identifying people that has high hypertension, to slow rising from sitting from a chair to get out of bed. Medical management, so looking at people with that hypertension, bradycardia, tachycardia, so if they've got a cardiac condition. And again, if they're on statins or blood thinners, warfarin, for example, you're going to need a separate strategy for those. Visually impaired, so making sure that you've got opticians visiting the home, but equally for dementia, because let's not forget there's some medications that cause hallucinations, which can put people more risk of falls. And then medical devices to manage the risk of falls. So that could be things such as the hip protectors, the alarms, the bed alarms, etc. So making sure that you've got those array of medical devices prescribed. So this is the most important part. This is the fire drill bit. This is the bit when you need to act when a fall has occurred. And you need to make sure that all staff follow this to the letter, because if they don't, I can assure you, when CQC do a forensic review on this, they will pull it apart. So here we need to look at what happened. We need to find out things around manual handling, how we're going to assess them, and how we're going to treat that individual. So the initial actions for post-fall, if a resident falls, the post-fall protocol should be see appendix 5, so we'll have a little lower down, and that should be laminated and in place in the office. So you can laminate this and have that everywhere. So let's go to appendix 5 now, actually. Normally right at the back, the appendices. There we go. Appendix 4, appendix 5. There you go. So, nice flow chart there. Nursing assessment of suspected head injury post-fall. Resident has fallen, witness head injury, unwitnessed, not sure if a head injury. Nursing staff do neurological observations and ask for a medical review. Medication must be inspected for anticoagulants. So just, make sure if you have somebody who's on anticoagulants or blood thinners or hypertension medication, that they get offered or an opportunity to have further investigations by the emergency practitioners. Avoid sedative medications if possible. We obviously want people to sleep. So if the GSC score is 15 to 15 and other observations are normal, neuro observations are done, half hourly for 2 hours, then 4 hours, then 2 hours medical review, 12 hours passed since the fall, it should be handed over at all shifts, and then that can be watched. And obviously if it's not, then the worrying signs shows there that we need to be looking out for. So we're obviously looking at residents who are increased risk of bleeding, in other words, those that have got liver diseases, anticoagulants, and other worrying signs. So that's the first thing we should look at there. So these forms are great. They're clinically approved and written, but just double make sure that they fit in your policies and procedures. And even if your home does not have nurses, you can still carry out these checks, because ultimately you need to make sure if somebody's deteriorated or not, whether or not that's happening in front of you and you're not responding appropriately. So if somebody has had a fall, we should do our vital sign checks using the news score, the National Modified Warning Systems. That's your blood pressure, pulse, oxygen, temperature. Depend on the news score, would depend on the outcome there. But equally, all residents who have fallen should be checked for signs and symptoms of a hip fracture, spinal injury, and head injury. See Table 3. So again, rule that out. Now, in your notes, you should write there were no obvious signs of ... Okay. Neurological observation should be performed on residents, so that's when we look at the eyes. We're making sure that the eyes are the same dilation and they're dilating at the same speed. So neurological observation should be performed, has been observed if they hit the head or fallen, report hitting the head or if they've fallen, has been observed to fall, is unclear, has been found on the floor. So if the resident has not been witnessed, so e.g. the resident was found on the floor or the resident cannot recall the event, it should be presumed that they have had a head injury. Moving a resident with potential spine injury obviously could be dangerous, so we want to keep them safe and mobilised, maintain their airways, and call for your emergency protocols. Any observed environmental hazards which appears to contribute to the fall should be made safe as possible. So what we're looking for here then is that escalation of help. So we've got our enhanced care practitioners, so that'll be your 111, that could be your ACPs or whoever it is. You're going to have their details there to forward. Equally, the residents should be informed by the nurse in charge or the person in charge as soon as possible if what action is going to be taken to treat their injuries. Any incident report should be completed by the nurses staff or care staff, and the resident risk assessment should be updated immediately following a fall. A fall should trigger a review of the falls management plan. So it may be the fact that you just write no change if nothing's changed. If they're already on everything that you could possibly do, you've reviewed it, but you need to show that you have reviewed it. And equally, it may be the case that you're showing that you're escalating this and you're trying to get more help. Equally, auditing and monitoring. So we need to make sure, in line with the NICE guidelines, that you monitor falls on a regular basis. And again, you look at the training. So here, this policy is part of the Back to Good program, which includes physical health projects. So that's their e-learning platforms. It looks at the training for the staff, so what they should be doing, and then this obviously links to other policies. Now, this policy is relatively straightforward. It's a very straightforward policy. Please go back and read your policies in your homes. Be mindful that you should have a risk assessment and management plan for falls. So this is what the hospital ones look like. Yours may look very different. So make sure that they are up to date and that they are reviewed. Here, you've then got your nursing post fall assessment form. So here, nursing assessment post fall, call for help, check airways, breathing, disability and examinations, ensure safety for staff, establish if they're in pain, establish what's happened, look for injury, and calculate the new score. National Early Modified Warning Scores. Call for an ambulance, well, it won't be 2222, it'll be whatever yours is. If they are unresponsive, if they've got cardiac arrest going on, do not move the patient fully until assessed by the appropriate person. So you need to decide who that appropriate person is and whether the appropriate person. Suspected hip fractures, yes, no. So this gives you a yes, no thing. Suspected fractured limbs, yes, no. And suspected spinal injury. So that's your signs and symptoms there that you can go down. So ultimately, if you are following the risk management plan there, you should be absolutely fine. You're covering everything that you need to cover. Make sure that when you read the linked policies here, that you do read those. So for example, here, this policy links to your health and safety, incident reporting, risk management policy, back care and manual handling policy. It should also have on there, so I think the other two policies it's missing, is your medication policy and warfarin or blood thinners policy. So just so it has a link. Anyway, the idea of this hot topic is just to raise awareness again around falls prevention, just to make sure that you understand what they are, that you're reading them, that you're up to date, that you've read the new NICE guidelines, and you're keeping up to date on all of those things. Conduct your practice sessions and make sure that you know what to do if somebody has had a fall and that what you are doing is in line with national guidelines.